Now, high anion gap ketoacidosis or acidosis is specific, and it's because of ketone bodies, and the ketones are ketoanions, and they are not usually measured in our routine investigations, so we have to use a ketone assay to look for them. And there's a simple formula to calculate for it, and that is to, as we said, subtract the positive from the negative ions in your plasma, and you're going to get a number. And that number is supposed to be the normal number, something between 11 and 14, for example. And if you get something like 17 or 18 or above, then you know you have a high anion gap. And that means there are anions that are not accounted for. And so you can postulate that the difference, the gap, is probably accounted for by ketones, given the clinical picture that you're looking for. And so you test for ketones in blood or urine if you don't have the blood strips or assay, and you find that. All right. So what is the definition of ketoacidosis? But we just discussed the whole idea of pathophysiology only to kind of summate in a simple definition. Diabetic ketoacidosis may be a complication existing with type 1 diabetes mellitus, and it might be the first presentation thereof, accounting for around 6% of all type 1 cases. Rarely, under conditions of extreme stress, patients with type 2 diabetes mellitus may also develop DKA. And those patients, that reminds you of the example that we discussed slightly earlier. Whilst diabetic ketoacidosis remains a serious condition, mortality rates have decreased from 8 to 1% in the past 20 years. And what that tells you is that's because of the advances of medical treatment, because of lectures such as this, I hope, that increase recognition and standardization of treatment. So alcoholic ketoacidosis is a non-diabetic, euglycemic form of ketoacidosis. It occurs in people who regularly drink large amounts of alcohol. Even alcoholics will not eat regularly and may vomit food that they do eat, leading to episodes of starvation. And once the person becomes malnourished after an alcohol binge, the body can start breaking down body fat, producing ketones, hence the patient develops a ketoacidosis. It typically presents with a pattern of metabolic acidosis, elevated anion gap, elevated serum ketone levels, low or normal glucose concentrations, but you can have high ethanol content in the body. The most appropriate treatment is an infusion of saline and thiamine, as opposed to in diabetic ketoacidosis, it'll be saline and insulin. Thiamine in the alcoholic ketoacidosis is required to avoid Wernicke's encephalopathy or Korsakoff psychosis. What precipitates diabetic ketoacidosis? The most common precipitating factors of DKA are infection, missed insulin doses, and myocardial infarction. So you want to look for those three. So a patient comes to me in the emergency room and I suspect ketoacidosis. They are coming with some dizziness, dehydration, abdominal pain. Those are some of the more common symptoms. And so in that case, I come and ask the patients are going to have polyuria, polydipsia, dehydration. They might have the Kussmaul signs where there's deep and deep hyperventilations. And you might have acetone smelling breath, and in that case, the acetone smell breath is like pear drop smell, and that gives you an idea that this patient might have ketoacidosis. And so you go ahead and do your measurement. In that case, this patient, by the time you have gotten your consult and seen the patient, you're going to do an ECG, enzymes, chest x-ray, and do a pan culture or a septic screen. So how to diagnose? This is from the American Diabetes Association 2009 and from the Joint British Diabetes 2013. The idea here is to tell you that you want to use your local hospital guidelines or local guidelines to know the exact definition, but the concept is almost the same everywhere. And so you have a high glucose, a low pH below 7.3, a serum bicarbonate that is lower than normal, so it is compensating. You're trying to buffer away the acid and you're barely catching up. A high anion gap, and preferably with ketone bodies, to know that the anion that is causing the gap, the extra anion in the body, is actually the keto anion, which is ketones. And you can have that positive on a ketone dipstick, or ketonemia if you have the blood test. Now, the principles of management, concepts you must understand and know by heart. You're going to know all of those by heart. You should be able to manage a patient if you don't have any specific guidance, and if you have certain hospital protocols, then it should be very easy for you to navigate through them. And so the first principle is fluid replacement, which most patients with DKA are depleted, and you need around 5 to 8 liters to compensate for the depleted fluid. Isotonic saline is used initially, and you want to really look at the fluid example that we're going to show you in a bit. And there's correlation of, you need to correct hypokalemia. Remember I touched on there's a lot of intracellular and extracellular shifts. So that also happens to try to compensate for your osmolality and for your positive and negative ions in the body to try to maintain isoelectric state. And so we're going to explain that now. But this is extremely important, because if you're going to have hypokalemia as you treat, because a lot of the potassium has traversed the cellular membrane, then you're going to have risk of arrhythmia and death. Insulin and intravenous infusion should be started usually at a rate of 0.1, because most of our patients that develop DKA are the type 1 diabetes who have lack of insulin, so the body is not resistant, so they're going to respond to a low concentration of insulin. And once your blood glucose is below 15 millimole per liter, an infusion of 5% dextrose is started congruent to the insulin. And below a certain drop-off point, you can stop the insulin and continue the fluid. And so the number one foundation is fluid. If you don't even have insulin, you start fluid, you might save the life with fluids only. Long-acting insulin should be continued. Short-acting insulins can be stopped, or in fact should be stopped, as you're going to be adjusting that based on your scale, based on your infusion, which means you're going to keep measuring the plasma glucose and adjusting your insulin rate as needed. So that's the Joint British Diabetes Society example of fluid replacement regime for patients with a systolic blood pressure on admission of 90 millimeter mercury and over. And so you're going to have 1 liter over the first hour, and then and 1 liter over the next 2 hours. So now we have a total of 3 hours, and then 1 liter over the next 2 hours. Now we have a total of 5 hours, and 1 liter over the next 4 hours. So that's 9 hours total. Then 1 liter over the next another 4 hours. So that is a 13 hour. Then 1 liter over the next 6 hours, and that's a total of 19 hours of treatment. So usually there is a potential for you to discharge a patient, or at least get them out of the intensive care setting within 24 hours. Please note that lower infusion may be indicated in young adults age 18 to 25, as they are at a greater risk of cerebral edema. And so it's a good idea to adjust your dose per kg whenever you see someone who has a petite body build. Children, young adults are particularly vulnerable to cerebral edema following fluid resuscitation and DKA, and often used as a one-to-one nursing to monitor neuro observations, headache, irritability, focal neurological deficits, and even visual phenomenon or disturbances. And it usually occurs in the first few hours, usually in about the first 10 hours or so following commencement of treatment, and can present at any time really, and can present earlier, sometimes even in the next 3 to 4 hours. So it's important to be vigilant from the moment you start the treatment and to not let anything for chances. And if there is any suspicion, a CT head and a senior review should be sought, and you can employ your neurologist if you have one in your center. The potassium levels in the first 24 hours. So the correction of potassium, we said we're going to give potassium and we're going to give it with each 1 liter, and usually about 40 millimoles per liter is given. But you're going to also monitor every 2 to 4 hours, usually depending on your hospital protocols. So we usually monitor every 2 hours. And basically, if the potassium is over 5.5, that's the only time we stop. But even up to 5.5, we continue, because we know that there's still a shift to the extracellular compartment, and with treatment, it's still going to go inside. And so we want to preemptively prevent hypokalemia. So we stay on the upper limit of normal, and below 3.5. You will add additional potassium usually, but it's also important to inform your senior or your intensivist to be on board with you. And so it is important to follow your hospital protocols. Usually those things are specified, and in fact, that's why those protocols are made in the first place, to kind of standardize the treatment, the order treatment set in a way that the physician and the nursing staff are very familiar with reading, as opposed to having long order sets that are written in a different manner by each doctor every time. The complications of DKA and its treatment, so they're not just the complications of DKA. If you don't treat DKA, you can have complications. And if you mistreat DKA, you can have complications. So gastric stasis can occur, especially with electrolyte imbalances and with acidosis, because that affects feedback loops, and you can have that kind of lack of motility. And thromboembolism can occur because of the dehydration, hyperviscosity, and the baseline level of inflammation that increases, especially when compounded with an exacerbator being inflammation or a vascular phenomenon. Arrhythmias, especially secondary to hyperkalemia or iatrogenic hypokalemia, hence we say complications of the treatment itself. And that's why we stress a lot on the potassium. Iatrogenic due to incorrect fluid therapy, cerebral edema, hypokalemia, hypoglycemia, and acute respiratory distress syndrome, and of course acute kidney injury, because you can have dehydration, so you have a pre-renal injury. So that summarizes the treatment concepts and the complications of DKA and its treatment that must be avoided. I hope you found this useful.